So first of all, thank you very much, Marta, for inviting me. It is always a pleasure to be at the Mediterranean Motley Forum, and it's my third time, I believe, here, and I'm always delighted to come back to Sicily. Secondly, thanks to you all for being here and for everyone who is online. And I will move us slightly this morning to talk about eating disorders. So I'll try and work out how this goes. Okay, so I will move slightly just to see what I'm telling you. I will talk about a few things today. First, just to give you like a brief recap of eating disorders. Some of you might be very familiar with eating disorders, some of you might not. So I thought I would give you like a gentle reminder of what eating disorders are. I will then talk a little bit about some of our work on whether eating disorders are becoming more common and studies on the prevalence and incidence of eating disorders. And then I will move on to talk about some new insights on the biology of eating disorders. And by now, thanks to Catherine and Isabel, you are pros in understanding genetic work. So I will build on that to talk a little bit about the work that is being carried out on the genetics of eating disorders. And then I will move on to talk about how that might impact and has in fact changed some of our, or starting to change rather, our treatments in eating disorders. So first of all, just a really polite suggestion that I have purposely included some slides on very, very new work that either my lab or my collaboration with the Psychiatric Genomics Consortium for Eating Disorders is doing. And these are all slides on work that is currently being done, so it's not even on bioarchives. You're almost the first to hear this, so it's great, but the downside of that is that I'm going to ask you not to take any pictures, please, because it's really new work, and I will tell you when that is the case. So first of all, you all know probably that eating disorders have become like a bigger pool of disorders in our new classification systems. So in DSM-5 and ICD-11, we have many more eating disorders than we used to have. So you will see the kind of classical eating disorders at the top, but then binge eating disorder, which has become a full-blown disorder, a disorder in its own right in DSM-5 and ICD-11, and then a range of other disorders, including avoidant and restrictive food intake disorder, ARFID, which is the new kid on the block, so the new disorder that came in DSM-5, and we also have pica and rumination, which I will not be talking about. So I will mostly focus on the black disorders that I've highlighted. Anorexia nervosa, the majority of you will probably know what anorexia nervosa is. Anorexia nervosa has been around for a long time, and it's a disorder that it's mostly characterized by food restriction, and this food restriction leads to a low body weight that is lower for age and sex and developmental stage compared to what it should be. It is also accompanied by an intense fear of weight gain or behaviors that counteract weight gain, or rather that prevent weight gain. And you will also know that anorexia nervosa is much more common in females than males, with a ratio of about 9:1. Next is bulimia nervosa, again around for quite a while. Most of you will know what bulimia nervosa is. Bulimia is characterized by episodes of binge eating, so-called binge eating because we have periods of overeating, so eating a lot of food in a short space of time and accompanied by a sense of losing control so that you couldn't stop even if you wanted to. And these behaviors are accompanied by so-called compensatory behaviors, so behaviors that are driven to with the aim of counteracting the weight gain that might be produced by an episode of binge eating. And usually these compensatory behaviors are either self-induced vomiting or use of laxatives or other medicines for weight loss or excessive exercise or dietary restriction. And we also have a cognitive component in bulimia nervosa, and that is high weight and shape concern. And there is a frequency criterion, of course, so you need to engage in binge eating and compensatory behaviors at least once a week for 3 months. Oh, sorry, and I should have said, for bulimia, as for anorexia, females are usually more at risk, and the disorder is more present in females than males, again a ratio of about 9:1. Binge eating disorder, as I was saying, became a disorder in its own right in DSM-5, and binge eating disorder, as the name says, is characterized by binge eating episodes. And these binge eating episodes occur at least once per week over the space of 3 months. And the distinction between binge eating disorder and bulimia is that in binge eating disorder we don't have the presence of compensatory behaviors, so it's a pure binge eating disorder, as the name says. And also it's often marked by a strong sense of distress and often shame and guilt in sufferers. And together with the binge eating behavior, we have a range of behaviors that might be eating too much, eating too fast, so eating more rapidly than normal, eating in the absence of hunger, or until uncomfortably full, etc., etc. But the mainstay is really binge eating behavior, and I would like you to bear that in mind for later. Now, contrary to anorexia and bulimia, the evidence suggests that, in fact, for binge eating disorder, the female to male ratio is probably closer to 1. From what we know at the moment, it's about 3:1. So binge eating disorder is relatively common, I would say, in males. Of course, as in many other disorders, in eating disorders, we have a range of eating disorders that are otherwise specified, and the reason why I'm listing them here is because some of them have become more important and are starting to be better studied as we speak, and some of them might actually make it to kind of full-blown diagnosis in the near future. And particularly atypical anorexia nervosa, similar to anorexia, but characterized by the fact that even with the weight loss, people are at a normal weight. And then, of course, the subthreshold disorders for bulimia and binge eating disorder, and then purging disorder, also relatively new, where we have compensatory behaviors, like in bulimia nervosa, but no binge eating episodes. And then the new disorder that was introduced in DSM-5 and ICD-11, avoidant and restrictive food intake disorders, also called ARFID. And ARFID is slightly different from traditional eating disorders, and in fact it comes from the feeding disorder literature, and it used to be characterized under feeding disorders in the child section of DSM and ICD. ARFID is characterized, as the name says, by restricted amounts of food, so it's either amounts or range of foods eaten by an individual, and this restriction of food needs to have severe consequences. However, there are some exclusions criteria, so in fact, the restricted amount or range of food is not explained by weight and shape concern, so it's different from anorexia or bulimia nervosa. It's not explained by lack of food or cultural practices, and it's not explained by another mental or somatic disorder, although there are kind of slight exceptions that I won't go into detail. And the severe consequences need to be either significant weight loss or failure to growth in a developmental phase, nutritional deficiencies identified by kind of blood tests, etc., dependence on enteral feeding or nutritional supplements, or marked interference with psychosocial functioning. So all of this constellation results in a diagnosis of ARFID. And for the rest of this talk, I will not necessarily talk about ARFID because we have a lot and don't have a lot of time, but also because it's a newer disorder where we are only starting to understand it. So just a recap of feeding and eating disorder, you will see from this slide and from what I've told you that eating disorders in some ways occur on a spectrum of BMI, in that anorexia nervosa is characterized by low BMI, bulimia nervosa usually at normal BMI, and binge eating disorder very comorbid with overweight and obesity. About 60% of people who have binge eating disorder are also overweight or obese. ARFID, in contrast, can occur at any BMI. What do we know about how common eating disorders are? This is a recap from a systematic review that was done some years ago. And figures often change in any study that you might see because of ascertainment of cases, of course. But this particular study tries to put together different studies that had been carried out in the past and suggested that lifetime prevalence of anorexia nervosa is around 1.5, very broad confidence intervals as you see for women, and about 0.2 for men. Bulimia nervosa around 2%, again really, really wide confidence intervals for women, and about 0.6 for men. And binge eating disorder, as you can see, by far the most common eating disorder, at about 3%, again, very wide confidence intervals. We think the prevalence overall of binge eating disorder might be more around 5%. But this is for women, and then about 1% for men. So, eating disorders are relatively common, we can see. The overall prevalence, if we take all eating disorders into account, is between 5 to 10%. And there is evidence that eating disorders might be increasing in prevalence and incidence. And this is where I will start showing you like the new findings. So just a reminder, please, not to take any pictures. So this is data from one of my postdocs. We have just finished analyzing some data from the Danish registers. Those of you that know a little bit about Scandinavia will know that we are very lucky because we have population-based registers that account for the whole population. And these are registers that take into account everyone in the country who has received a diagnosis of eating disorder from secondary and tertiary care. Eating disorders are diagnosed only in secondary and tertiary care in Denmark. And as you can see, these data show changes from 2000, the blue bar, orange, 2010, gray, 2022. And you can already see from this very simple graph that the prevalence of diagnosed anorexia nervosa has almost trebled in these 20 years, similar for bulimia nervosa, and even more so for other eating disorders. Because in Denmark we don't have ICD-11 yet, we cannot distinguish binge eating disorder, unfortunately, but have to include any other eating disorder that's not anorexia and bulimia in a broad category called other eating disorder. So you will already see from this that the numbers of individuals who have an eating disorders have dramatically increased. And this has not just occurred in Denmark, but this is a slide from a study from the UK, a study that uses the GP register, so primary care, similarly to the study I showed you before. These are data of people who have been diagnosed with an eating disorder. And what this graph shows, I've selected the eating disorder part, is that they split the trends in incidence of eating disorders by age group. And you will see, although it's fairly small, that the legend tells you that the pink line, or red line, represents youth between 13 and 16 years, the black line, people aged 17 to 19, and the blue line, children aged 10 to 12. So what this slide tells you, particularly if we focus on the left panel, which is girls, that the number of girls who have been diagnosed or newly diagnosed with an eating disorder over the last 14 years, from 2004 to 2018, has increased. And this increase has been particularly important for girls aged 13 to 16. So you will see that the number of new cases of eating disorders in the UK has almost doubled in these 14 years. We see a similar increase for boys, however, because the number of boys who have an eating disorder is much smaller, it's much harder to kind of pull these curves apart. But there is a significant increase also for boys in this pink or red line, so in the 13 to 16 year-old bracket. And the study showed that in fact by 2018, eating disorders is the third most common mental health disorder in youth, followed only third to depression and anxiety, as we would expect, but certainly an important impact on young people's health. These are data, again, from my postdoc, so new data from incidence in Denmark, and we have split the graph in a similar fashion in terms of age groups. And here I will point you to the 10 to 14-year-old bracket, the blue line. You can't see very well in terms of colors, but the dark orange is 15 to 19 years old. On the x-axis, you have time, so from 2000 to 2022. The graphs represent incidence rates, so new cases diagnosed with eating disorders, and again you have females on the left and males on the right. And the striking thing, again, is that you will see there's been a huge increase in incidence, again about threefold for young people aged between 10 and 14. And this is the case both for females and for males. And you will also see an increase for girls aged between 15 and 19. So again, similar data showing that this particular age group has been developing or newly developing eating disorders in a higher fashion as compared to the past. This is a UK study. Some of you will ask me, of course, that graph includes COVID, and there has been a lot published on the fact that during the COVID pandemic, more people seem to have developed an eating disorders as compared to before. And the graph that I showed you before kind of seems to hint at something similar happening, like following 2020 with a kind of a sharp rise in increase, although we seem to be seeing like a return to the mean. But in any case, this has been studied more in depth in a UK study, and again, this UK study suggests that following the pandemic and the early pandemic in 2020, there has been a sharp increase in new diagnoses of eating disorders, again, both for girls at the top and for boys, but particularly striking for girls. And you can clearly see the base rate prior to COVID, 2019. Of course, a drop in 2020, particularly early 2020, because we were not seeing cases at that stage, and then a sharp rise after that.
Could I just ask you a question? I can see that most of the study looked at a maximum 2024 or 24-35. Is that because we don't see new onset eating disorder later on in life in both genders, or because people have looked so far at these age groups?
Very good question. We know that eating disorders can start in the kind of fourth decade of life, but the numbers are so small that it's very difficult to kind of plot them in a meaningful way. But great question. So just a hint, because COVID, of course, was an environmental factor, and we haven't necessarily studied what that might have meant in terms of an environmental risk factor, but just a placeholder for you to think about that. Because we will now move on to talk about risk for eating disorders. And of course, I've been saying that eating disorders are common. They might be becoming more common than they were. They have high physical morbidity and high psychiatric comorbidity. But also, we know relatively little about risk mechanisms. In some ways, as a field, we are behind schizophrenia and depression because we don't know quite as much yet about why eating disorder develop as compared to these other disorders. But also the important thing, and I think why I love working in this field, is that there is still a lot to study and a lot to do, because we don't have any biological treatment yet targets, or at least we didn't have any. We might do now, and I will be telling you shortly why. So eating disorders, like you've heard about depression and sleep, are complex disorders. And of course, we know that there is a genetic component. We also know that there is a strong environmental component. I will not talk about environment today because that would have taken me the whole morning. There are a few factors hinted at here that you might gather. Luckily, the understanding of genetic factors has dramatically increased in the last 10 years, thanks to everything that Catherine was saying this morning, GWAS and post-GWAS work, and the drop in price for genotyping, etc. So we know much more than we used to on the genetic component of eating disorders. So again, these are slides that are hot off the press. Please don't take pictures. And this is an analysis that is ongoing. We have just finished the third wave of GWAS for anorexia nervosa. And we have identified 8 loci. Catherine told you everything about what a Manhattan plot looks like and what we can gather from it. And the current GWAS for anorexia includes about 24,000 cases and about 1 million controls. And we can see that there are 8 loci that have come up as significant. And these loci and the genes that are kind of linked to these loci are mostly genes that are expressed in the brain and genes that are associated with metabolic traits. We are still kind of finalizing the analysis, so I won't show you the detail here, but trust me. We also have started to look at the genetic correlations between anorexia nervosa and other disorders. And again, you've heard what genetic correlation means. And you will know that everything that is in green means that it's a positive genetic correlation. So anorexia nervosa shares some genes with the disorders that are highlighted in green. And here I'm just showing psychiatric and behavioral phenotypes. And you will see that the usual suspects come up. So, of course, the reality check that anorexia nervosa is related to anorexia nervosa from the previous wave. So we haven't done anything wrong. But the important things here are obsessive compulsive disorder, strong association, strong genetic correlation, I should say, with anorexia, and schizophrenia and bipolar. Exactly. I was going to wait for somebody to point this out. We know, or those of us that have known individuals with eating disorders and have worked clinically will know that usually people with anorexia are rather avoidant and have low risk taking, and this probably represents that genetic propensity. Interestingly, there is a negative correlation with subjective well-being, which one could gather. If we move to anthropometric and metabolic traits, what you see in this picture is the exact opposite. So we've known from the previous analysis of genome-wide association studies that anorexia is strongly negatively correlated with anything that relates to obesity, high BMI, waist-hip ratio, fasting glucose, insulin, etc., etc. I won't bore you with the detail, but you can see that pretty much everything that's on this slide is on the red, so it's negatively correlated, which means that genes that might predispose you for obesity protect you from developing anorexia nervosa or vice versa. So that's what a negative genetic correlation means. The only thing that you will see positive here is HDL cholesterol, which some of you will know it's kind of a positive in some way metabolic marker. So again, that makes sense in this context. Why I believe that's important? That is important because since the first GWAS studies started, our thinking about anorexia nervosa has shifted, and has shifted quite a bit. From our thinking that anorexia nervosa might be just a psychiatric disorder, we have started understanding anorexia as a disorder that might have a metabolic component as well as a psychiatric component. And therefore, that the biology that underlies somebody developing anorexia nervosa might predispose them to developing the disorder. So there is a combination of factors. We still don't know what that metabolic component is, but this has really started a spike in work trying to understand what that metabolic component is. And it might be, I often say genetically we are caveman, although, we live in a very complex world, very far from when we were in caves, but genetically we are kind of primed to, or, we are what we were when we lived in caves. And it is easy to understand that there might have been adaptive mechanisms to famine and starvation that might have been important when we lived in caves, but that now, with the obesogenic environment that we are living in, don't seem to make sense. But there might be something there that goes awry and that leads to anorexia nervosa. The reason why I believe we are in an interesting era for anorexia is that those studies have led to new developments and new ideas or new treatments that are being tested. This is a study, for example, that used leptin, the type of leptin that can be given to humans called metroleptin, and that used metroleptin in 3 cases. And I'm just putting here the plots from the paper that focus on 2 of the individuals that received leptin. And there is a trial, an international trial that is underway. So, in some years we will have the results of that, but it's certainly interesting. The initial trial on the 3 patients is not terribly convincing, I have to say, but what they do show is that there is a decrease in repetitive thoughts. I know it's very small, but it's the blue line. And improved mood. So whether leptin acts by those mechanisms to affect or to impact on changes in anorexia nervosa, we don't know, but certainly this work is going on, and certainly will tell us more about risk mechanisms and the pathophysiology of the disorder. Other interesting studies that are going on, focusing on treatment targets in the brain, studies on psychedelics. I have the feeling that psychedelics are everywhere in psychiatry at the moment, but they have certainly started being used in anorexia nervosa. Very interesting, and this is a study that's being carried out at UCSF in San Diego, and this is a pilot, mostly a phase 1 feasibility study, but there is now a bigger trial going on. Some colleagues of ours are also starting a trial using ketamine, so there's more coming out. This particular study, again, wasn't terribly convincing in terms of symptom change. This is the eating disorder global score change, and you can see that in the 10 patients that underwent this trial, there wasn't like a huge change, maybe a drop for some, but not for everyone. However, the study showed that psilocybin is safe, tolerable, and acceptable, so there is a larger trial going on. So very, very interesting times. But what's happening with other eating disorders? So this is a study that we did some years ago, where we used data from the UK Biobank and looked at genetic correlation and polygenic risk scores. Again, you've heard about polygenic risk score. And what I'd like you to focus on in this slide is the kind of purple and red dots showing binge eating disorder and bulimia nervosa. and the green dots showing anorexia nervosa. And what you will see here is that the dots aggregate pretty much in the same way. So again, 1 is an odds ratio of 1 means no effect. Anything on the right side is a positive effect. I should say that the open dots mean that the result is not significant, and closed dots that it is. But what I want you to focus on is really the shape of the graph. And you will see that all 3 disorders really cluster on the right side, which means a positive effect. So all 3 disorders seem to share similar psychiatric risk. However, when we looked at metabolic and anthropometric risk, there is really a large difference, particularly here at the bottom in anthropometry, where anorexia nervosa seems to cluster on the left side, like what you've seen in the genetic correlations, whilst binge eating disorder and bulimia cluster on the right side. So they have an opposite relationship with anthropometric and metabolic traits. And this leads me to the second part of the work from the Psychiatric Genomic Consortium Working Group for Eating Disorders. Again, these are the new data, so don't take any pictures. And this is a new GWAS that we've carried out on binge eating behavior. So not binge eating disorder, but just the core behavior, which is binge eating. And here we have a broad definition of binge eating, and that includes 39,000 individuals versus about 1 million controls. And again, our lovely Manhattan plot. And what the GWAS shows is that there are about 6 loci that are significant, and lo and behold, the strongest one seems to be FTO. And I'm sure you know about the FTO gene, which has been implicated for a long time in obesity. And in fact, one of my first ever genetic papers was on the role of FTO in binge eating disorder. So it's nice when things kind of come back to full circle. And again, the genetic correlation for binge eating behavior tell us things that I showed you in the previous graphs, in that, again, there are positive genetic correlations with psychiatric traits and disorders, so relatively similar to anorexia, bar from the risk-taking. So you will see they're all positively genetically correlated, but what do you think the next is going to show? Oops, sorry. When we look at anthropometric and metabolic traits, very, very different for binge eating as compared to anorexia. So everything is positively correlated with obesity, waist-hip ratio, high BMI, etc., etc. So all the kind of obesity type or weight gain type anthropometric traits, apart from persistent thinness. But again, that goes without saying because it's the opposite of obesity. And pubertal growth, again, which is linked to a kind of fast growth. And fasting insulin, which of course is on the negative side because we are talking about markers that are related to weight gain, obesity, etc. So it seems to make sense if you think about that kind of BMI curve that varies across eating disorders. And I've pulled out the difference here between anorexia and binge eating, just to kind of clarify them. And again, it is very interesting that, as we would expect, obsessive-compulsive disorder is significantly positively correlated with anorexia, not with binge eating. ADHD, which we know is genetically correlated potentially with binge eating disorder, binge eating is positively associated with binge eating, but not with anorexia. We see that in the clinic, that kids who have or have had ADHD are at higher risk for binge eating and binge eating disorder. And substance use, again, we know from the clinic that individuals with binge eating disorder or bulimia are more likely to engage in substance use, and you can see it here in the genetic correlations. You don't see it with anorexia. And age at smoking initiation, again, is the opposite. So people who start smoking late I mean, start of smoking late is genetically correlated to anorexia because, again, that there's kind of low risk taking. So you can see that pretty much there are some similarities, but also some important differences. Again, the risk taking different across anorexia and binge eating. Self-rated health, much more important or more genetically correlated with binge eating than anorexia. So again, you see patterns that you kind of saw before, but more pulled out and clearer here. And again, what I've been saying, so the real kind of difference in terms of anorexia and here binge eating behavior, but also the disorders that are characterized by binge eating and this kind of pulling of opposite relationship between anthropometry, metabolism, and the two kind of phases of eating disorders. What does that mean for binge eating disorder and other eating disorders? And I want to bring you here in the kind of last few minutes to kind of maybe one of the controversial areas that has hit eating disorders in the last couple of years. And I knew, this was a topical thing when my kind of last teaching to medical students a couple of weeks ago, one of the medical students in the audience did ask me, what about treatment for eating disorder using Ozempic or Wegovy? And so I thought I have to bring it here because it's a big controversy. So you all will have heard of the big hoo-ahs in the media, I would say worldwide, on the use of GLP-1 receptor agonists. And I won't kind of go into detail, but you might all know what GLP-1 is, a glucagon-like peptide secreted by the intestine in very different places and probably also in the brain. It's both a peptide and a hormone that has effects across the whole body. This is a slide taken from a book, a graph taken from a book, and you will see that GLP really has effects on all the organs, including the brain and very many other, of course, adipose tissue, liver, pancreas, heart, stomach, etc., etc. So very widespread in terms of receptor. And you will also know that GLP-1 receptor agonists have really taken the stage in the last few years. We know that the receptor for GLP-1 is expressed widely in the brain, so as I said, across the body, but very much so in the brain, and it is a potent regulator of food intake. And there are a number of ways in which receptor agonists get into the brain. They do get to the brain, and they have an effect, an important effect on hunger and satiety regulation in the hypothalamus. So they really act on the brain. And they also act on the brainstem, not just on the hypothalamus. There is some newer evidence that the GLP-1 receptor agonists might also have some neuroprotective properties, and there is also some evidence, new evidence, and I will leave it to the experts, but on mood and on kind of suicidal ideation, but very, very interesting molecules. And they've hit, of course, the world of eating disorders because of the potential use in binge eating and binge eating disorder. And there are preclinical data using animal models, in fact using two different binge eating animal models, that the GLP-1 receptor agonists may reduce binge eating like behaviors in animal models. But there have been also some studies in humans, first dulaglutide, and the study that was done using this molecule showed a reduction in binge eating symptoms in people with type 2 diabetes and binge eating disorder, small sample size. And it looked like the reduction in binge eating symptoms was also associated with a decrease in BMI. Of course, these drugs are very potent weight loss drugs, as you will know, and that's why they've become so controversial. So it's difficult to know, if their effect on weight loss is different from the effect on binge eating symptoms, or whether they are one and the same. But certainly, this kind of small study showed some effect. Liraglutide, a newer GLP-1 receptor agonist, showed a significant reduction in binge eating symptoms in a smaller study, only 44 cases. And the only randomized control trial to date that was carried out using liraglutide versus placebo in people with binge eating disorder showed a reduction in binge eating and a higher rate of abstinence from binge eating, but this wasn't significant. Again, a very small sample size, and there seem to have been some issues with randomization. So there's still a lot to do, and as you will see, there are no studies using the newest GLP-1 receptor agonist, semaglutide. In Denmark it's called Wegovy. I don't know how it's called in your country, but it's the newest GLP-1 receptor agonist that we hear about in the press. So interesting data, but there is a lot that needs to be done. There is some evidence that the GLP-1 receptor agonist might reduce binge eating and improve binge eating disorder, but of course, as I showed you, the evidence is far from conclusive. We need many more studies, and we need really large-scale, well-conducted, randomized control trials to know whether this is the case or not. Also, there has been a lot of controversy, as I was saying before, on GLP-1 receptor agonists and the effect that they might have in terms of misuse in other eating disorders. At one point, at the beginning of the year, I think every other day you could see something on the newspapers about somebody having gotten Wegovy or Ozempic just of the internet or in some weird ways, and somebody who had an eating disorder such as anorexia or bulimia having misused it for weight loss. So it's drugs that hold potential promise. It's also drugs that we need to watch out for because they might have impact on the other eating disorders. So an area that really needs studying. Just a little hint on our new research avenues, maybe things that I can be talking about at future Mediterranean Motley forums. In our work using register and large population data sets, we are working on studying individuals at high and low genetic risk for anorexia and binge eating, and looking at their morbidity and mortality using large population data sets to try and see what does it mean to be at high genetic risk for anorexia or binge eating. We're also studying psychological resilience in those at high genetic risk, again, to see if we can identify some potential protective markers that might help us in the clinic or in prevention efforts in the general population. And we're also investigating anthropometry, metabolic function and behavior and neuropsychology in children who are genetically at high risk for eating disorders. So you might hear some of those findings in the future. So without further ado, I want to thank you all for listening and ask for any questions. And thank, of course, the PGC-ED working group, who has worked tirelessly and provided the slides, and of course my wonderful team in Copenhagen. And before I finish, just a shameless advert. I'm looking for a psychiatrist with a PhD who might be interested in doing research in eating disorders.
Are you volunteering, Giovanni?
Yes. So feel free to share this with any colleague that you think might be interested, and there's a QR code and a link there. Thank you so much.
Thank you, Nadia, for the wonderful talk. So before I let Giovanni ask a question, we have this tradition of having talks that have anything to do with eating or weight before the coffee break. Yesterday we had one on the management of obesity where we had lots on GLP-1.
Nadia, great talk, but anything about psychosocial treatments? And demonstrations of effectiveness?
Mm-hmm. Great question. I would have loved to talk about psychological treatments, but because the task from Martha was to talk about research and its impact on clinical, I focused more on the new evidence. Of course, there is a lot of evidence for psychological treatment for particularly bulimia and binge eating disorder. The evidence for anorexia in adults is particularly controversial. We have a good treatment called family-based therapy that works for young people. However, we are still lagging behind for adults with anorexia nervosa in terms of psychological treatment. And that's why I think the new treatments are interesting, because they target that part of our patient population which is more resistant to psychological change. For bulimia and binge eating disorder, we have very good treatments, particularly CBT. In fact, for our scenes, we are carrying out a large CBT trial on binge eating disorder, certainly the largest in Scandinavia, that we are starting in the next couple of days. CBT has very good evidence for bulimia nervosa and binge eating disorder. And the evidence is starting for ARFID. There's a good treatment using CBT for ARFID. So there are very good psychological treatments. The thing to remember is that psychological treatment only has about a 60%, between 40 and 60% success rate in eating disorders. So although a lot of people benefit from psychological treatment, a large proportion of patients does not. That's why I think the future is really trying new adjunctive treatments and new biological treatments that then complement our toolbox when we treat patients. Great question.
Hi. Ooh. Hello. I wanted to zoom in on the factors that you looked at. It's like a super interesting talk. I wanted to ask you about neuroticism specifically, and whether there had been any testing of the other traits from the sort of ocean model, and is that what you meant by neuroticism, especially given that you looked at risk tolerance and that you intend to look at psychological resilience?
Great question. So of course we used available polygenic risk scores where we can look at those genetic correlations, and there is a good GWAS, genome-wide association study of neuroticism, meant as a personality trait, in the kind of big five sense. So there it's that particular sense of neuroticism. Oh, very good question. We are currently kind of starting a new study where we are actually looking at the overlap between eating disorders and internalizing factors in a more specific sense. So we'll be looking at some of those specific factors there. Thank you.
Thank you. Very interesting talk. I thought I'd make the most of the opportunity to ask a question to the expert. What about treatment with pharmacological therapy? Is there any evidence? I used to look after eating disorder ward many years ago, and I know some people would have depression as well, and I used to see a lot of mirtazapine prescribed. What's your view on that? Because of the side effect of, feeling extra hungry.
Very good question, and I should say that there are only two treatments that are FDA approved for eating disorders, and those are fluoxetine for bulimia nervosa. Fluoxetine at higher doses seem to have an effect on reducing binge eating, so there is some evidence for the use of fluoxetine in bulimia. And then the only other one is lisdexamfetamine for binge eating disorder. Again, some evidence showing some improvement in binge eating disorder using lisdexamfetamine. Of course, eating disorders have a high comorbidity with internalizing disorders particularly, and in that case, the use of SSRIs, for example, is kind of quite common. Mostly SSRIs. Mirtazapine is kind of not used that much, but certainly when there is comorbidity, SSRIs can be very effective. Although in clinical practice, I have to say that when people with anorexia nervosa are very underweight, the effectiveness might not be as strong because of the low weight and probably the kind of serotonin pathway in people who are underweight.
Hi, that was a really amazing talk, thank you. My question was about the anthropometric and metabolic genotypes and differences between, in particular, binge eating and anorexia. You showed there's a real clear divergence there across across the no difference line. My question is that would that difference still hold true within different subtypes of anorexia, for example, with a more clinical overlap with binge eating, like binge purge or atypical anorexia?
Very good question. We are starting to collect enough individuals with the two types of anorexia, so restrictive and binge purge, to try and understand that. So we don't kind of quite know. Certainly the GWAS of anorexia includes people with binge purge anorexia. So it seems that almost kind of the fact that you have anorexia trumps the fact that you might have binge eating behavior. And that really that differentiation might be more kind of in the result. And in some ways it's a bit kind of counterintuitive to show, because we know that people with anorexia are at low weight and people with binge eating more on the other side of the spectrum. But yeah, that seems at the moment to hold true also for people with binge purge anorexia. But we are starting to collect the samples to try and pull it apart a bit more. Great question.
Oh, this is a clinician. I have to say lisdexamfetamine is the only psychiatric drug that actually works in eating disorders. And boy, it really works. But people do get tolerant after a couple of years, so we have to help them.
Absolutely.
Use it judiciously.
I agree.
Anton, last question.
Hi. 2 years ago in Malta, I conducted a population-based study on eating disorders in teenagers. And we have seen a significant increase in boys. I wonder if this is something you're noticing as well.
Very interesting. I think, as you saw in the UK study following the COVID pandemic, there was an increase in boys as well. And certainly we saw that in Denmark too, with an increase in the incidence in boys. Now, it's always hard with these kind of studies to know, is it a true increase, or are we better as healthcare professionals at diagnosing them? I'm always a moderate, so I think the truth is in the middle, so there might be kind of both things. But I agree with you that certainly there seems to be an increase in boys, maybe not as pronounced following COVID as in girls, but certainly I think there is an increase in boys.
And Nadia, there is just one quick question online. Any evidence for the use of olanzapine in anorexia nervosa?
Again, very good question, because it's one of the other molecules where there has been a couple of RCTs, particularly a large one carried out at Columbia in New York, that showed some evidence for the use of olanzapine. And now most of the effect seems to be via increasing BMI. Of course, it's difficult to say, does that not mean that symptoms increase as well? So certainly there is some positive effect. The issue that we find clinically is that often people with anorexia don't want to take olanzapine because they know of the weight increasing properties. However, the evidence seems to say that it does help.
I mean, it's also the reason why among the substance of abuse you show, cannabis doesn't come up. They don't like it because it does increase appetite.
Exactly.
So the only population I don't have to worry about.
Exactly.
Thank you very much for the great talk.
Thank you.